Yeah, so I've got a patient who's a 73-year-old man with previously well-controlled type 2 diabetes whose adherence, we hear about this a lot, has declined over the past year. And his weight's 164 pounds, his BMI is 27.5, blood pressure needs a little work at 136/92. His A1C is at 7.7%, fasting glucose of 132 milligrams per deciliter, postprandial higher at 196, a GFR at 58, so just a modest renal compromise. And patients on lifestyle management, a maximum dose of metformin, insulin detamere at 34 units, which is really close to 0.46 units per kilo, really close to that sort of magic 0.5 units per kilo that we talk about when you need to start thinking about prandial therapy. Of course, he's got prandial therapy in terms of liraglutide at 1.2 milligrams a day, hydrochlorothiazide, aspirin, and then Flonase nasal spray in the spring. And he's had a history of grade 2 retinopathy, hypertension, seasonal allergies, and mild cognitive impairment. And not only is he dealing with mild cognitive impairment, which may definitely be affecting his adherence, but his wife was diagnosed with stage 3 breast cancer a year ago. So she may be part of the caretaker, and now her health is compromised. And so you can see that maybe what we need to do is not think about dramatically lowering his A1C, but maybe finding a regimen that might work for him. So would you see a benefit, Vivian, perhaps in taking 2 injections a day and making them 1 and maybe thinking about a co-formulation in this patient?
Yes, I would. I do feel here that there are some really important factors in this gentleman's life. He's developing cognitive impairment himself. And he's probably very stressed with a spouse who's got fairly advanced disease, maybe life-threatening disease. And so I don't want to improve glycemic control greatly. His A1C is 7.7. This fits in with the individualized goal for the AD of being between 7 and 8%. And I'm very comfortable with that. I would not want his control to deteriorate too far, because that's a slippery slope where he just, if he stopped taking his insulin, for example, he might get an infection and really deteriorate tremendously, get polyuria and polydipsia at his age. It would be tragic for him and his wife if he were to get ill. So I'm comfortable with his A1C. I'm also very comfortable with his weight being 27. His blood pressure is not too bad. I think overall the numbers are good. It's just the fact that he's got so many burdens in his life, and he's probably going to forget taking 1 of these 2 injections a day. So this is a very good opportunity to sort of consolidate his treatments. I would, combine. He's on detamere and liraglutide. Now that combination is not available, but you could use ideglara and choose a dose that's sort of halfway up, 25 to 30 or units of, or even go 34 units, although and he's likely to tolerate the liraglutide, so I'm not worried about the GI side effects. So this is an exception to the recommendation of starting right at the bottom and up titrating. It's not in the guideline, it's not in the package insert, but I would make a pragmatic decision here to go with 30 or even 34 units of the fixed dose combination, because that's what he's on anyway. It would really simplify his life and allow him to not have to deal with 2 injections a day.
And as you said, he's already on a middle dose of a fairly good GLP-1 receptor agonist. So one would expect, if you switch to a co-formulation, whether it's ideglira or aglar-lixi, that you probably don't have to worry about that slow up titration again, because he is experienced with his GLP-1 receptor agonist.
Right.
And so
the real reason for that, choosing that low dose, is to start low with the GLP-1.
Right.
That does not apply here.
That's
if
exactly
I was
right.
switching between agents, sometimes you probably do need to go down, because you can get side effects from a different GLP-1 receptor.
Right. But I think the other point that you make is, and they don't tell us the duration of diabetes here, but it says this patient has been previously well controlled with type 2 diabetes. So let's say he's had 15 to 20 years of well-controlled diabetes. Well, what we know is that now as he gets cognitive impairment, it's going to be just fine, as you said, to allow his A1C goal to be less than stringent.